So, welcome back. I hope all discussions were as active as in group one. I'll ask Beatrice. Beatrice, I see, there you are, Beatrice. If you could just come up and summarize the discussions from group one. Thank you.
All right, so in group number one, we had very active discussions in three subgroups around three topics. First one was it was all around the last target: 100% of people living with diabetes should have access to insulin and blood glucose self-monitoring technologies, to affordable insulin and blood glucose self-monitoring technologies. And we discussed this in three subgroups. So the first one was to discuss what does actually mean 100%. The second one was how should we measure it, and the third one was what does actually affordability mean. Okay? So what does 100% mean? Well, 100% of people needing to have access to affordable insulin and glucose test strips for self-monitoring means everybody in a particular country who lives with type 1 diabetes. I think that's very clear what 100% means, but actually how is this then measured at the country level? Do we accept that a country reports, yes, we have 100% availability if every health facility stocks the products, insulin and glucose self-monitoring technologies to be used for self-monitoring? Or does it actually mean every person living with diabetes has the products in their hand? So is it the facility measurement or the person-focused lens of availability? I think that we discussed there were pros and cons to both. So at the facility level, that is also what WHO has in their monitoring framework to a degree, where facility availability and stockouts are being measured of insulin only. We'll come to that in a minute. But does it actually reflect the real need, right? And also, does it really account for other access issues that people may have, such as transportation, to the nearest facility? That is an impediment to access to products if a person cannot actually get to that for various reasons, So if we count at facility level, we'd be missing that picture. If we look at it from the person perspective, of course, those issues would be accounted for, because if a person says, no, I do not have access to these commodities, then that means something is wrong in the entire chain of actually getting to these products, and that can then be addressed. However, of course, we've heard it many times during the day today, that if you don't know how many people actually live in your country with type 1 diabetes or in a particular country, then it is not possible to say when 100% has been reached. So that definitely requires strong registries. And lastly, we also discussed, interestingly, when do we accept that the government says, yes, 100% of people with type 1 have access to these commodities? Is it when everything is paid through the government, or is it when part of the supply is actually being paid through donation programs and other parts are paid by the government? We had mixed opinions, right? Some people felt strongly it's actually only when government, provides everything. Others said, well, from a person-centered perspective, it makes no difference as long as that person has a supply. So that was on what is actually 100%, quite some deliberation. Then the next group discussed about measurement, and that feeds quite well into how do we look at the 100%? Do we look at the facility level? WHO, the Global Monitoring Framework, says that one should measure stock out for insulins. The group felt quite strongly that that is not all. It should actually be more granular to say, okay, all types of insulins on the essential medicine list or on a particular country's EML. It also, which it doesn't currently, must include availability of injection devices, glucose meters, test strips, and lancets, of course. Also, the WHO Global Monitoring Framework, in terms of measuring, falls short of measuring availability for self-monitoring. It does talk about plasma glucose testing in facilities, but not if a person can actually self-monitor. And here comes the group's discussion in around measuring household availability, so taking the person-centered approach, that actually this is the way to measure ability and to have access if looking at household surveys. So there were some gaps and opportunities identified here. Affordability, I do justice to the group in having captured what's been discussed. So I think it was agreed that there was a complex topic. It really depends on the needs, particularly when it comes to glucose testing needs, and hence cost and hence affordability may vary greatly depending on a person's regimen and need, for managing their condition. And I understand also what's the comparator, right? Of course, there's a global idea, the WHO guidance through international work to say it should be compared to the pay of the lowest paid unskilled government worker. But of course, that can vary greatly by country, and that might be a challenge for some countries to define that threshold, to say, okay, how do we define affordability, and how does it actually compare to an average cost of the bundle of care of insulin, glucose meters, and test strips and injection devices. So affordability is not an easy one to define. As much as there are wonderful guidelines and data how to assess affordability at a country level, it may need some concerted efforts to actually put that in place. And I think that was roughly the summary of what we discussed in our group. There might be opportunities later to ask questions or for other group members to come in. I'll leave that up to you, David. Thank you.
Thank you very much, Beatrice, for that summary. We'll have the summaries from each of the three groups, and then we'll call back the three rapporteurs to have a discussion. But I'll hand over for Group 2. Bent?
Just before we have the feedback for Group 2, just to say that once we are through with the closing of day 1 in around 6:30, we will go straight to the dinner, which is served at the restaurant at the bottom of the hall to the left. Tonight is not the buffet, it's the seated dinner. You are all invited already, of course. So with that, we will go to group number 2. And group number 2, we don't have it here, but in the program you can see it. It's the governance stream, discussing different governance aspects of type 1 diabetes care policy, financial and technical, discussing the ownership frameworks for engaging in type 1 diabetes care, and of course resourcing mechanism, and distinguishing freely between local, national, and international levels. And in that perspective, we met in the group and looked at these different objectives, and particularly the element of sustainability, as we put in the program, perception of sustainability in type 1 diabetes care. And I'm sure the way we had also framed Group 1 and 3. These groups were meant to be a forum for knowledge exchange and sharing of perspectives, but also respecting that we have convened a very diverse group of stakeholders here in Copenhagen, whereby the perception of sustainability from one agency can be very different from the perception of sustainability of another stakeholder, just as other questions are perceived differently. The objective of the groups are exactly that, sharing of the perspectives and starting a conversation. We put in the outline of this group around governance whether it would be possible to start defining an operational definition of sustainability, but let's see. At least we got started in the group. And I would like to invite we will actually split the feedback between the three subgroups we had. So I believe it was Archana from India, please. And it was Sanjana from WHO. Are you back? Sanjana? Yes. And then it was Suzanne. Is she here? Yes. So I think we just do it the sequence we did in the group. So you'll start, Archana, please.
Thank you. So we discussed policy, resources, and sustainability. In policy, we were 6 different countries, yet everyone had an NCD program. The problem was half the people where NCD program existed, type 1 diabetes was not included. And the other half where type 1 diabetes was included, the countries did not have enough financial resources as a government to be able to give continuous supplies. So at both levels, we found that lateral ways of convincing the government would have a big big effect. For example, in India, it was with the school program, with the Child Protection Act rather than the health program, that a lot of policies were be able to drive it into the NCD program. So driving policy in their own country through lateral programs was consensus that we came to a conclusion. Resources, currently all the countries, 6 countries that we were there, it was mainly supported by philanthropy and NGOs and by different groups, patient support groups. So resources had to change and everyone agreed for sustainability. It has to be government supported, it has to be health insurance, and for sustainability, capacity building of HCPs as well as people living with type 1 diabetes and registry. I think concluding, everyone wanted a registry which would drive all the 3 aspects. So that was our group 1 discussion. Thank you.
Our group built off of what was just shared, in that it was difficult to have governments prioritize type 1 diabetes, even within national NCD programs. And when we talked about sustainability, one topic that came up was leveraging and connecting with other agendas like maternal and child health. But that was also a debate as to whether even when you link and leverage those agendas, does type 1 diabetes get the priority that it needs and deserves? Given the restricted finances, one thing that we spent a lot of time talking about was actually leveraging the community and bringing the community into the governance structure and ensuring that those who were actually impacted by the decision making were included in that process. And so we had Bastian who complemented this discussion with a wonderful visual of the government and the community and building a bridge, and the term policy entrepreneurs came up as well as something that was needed in part of the governance discussions.
The third part of the group discussed about identify the different stakeholders that are implicated in the type 1 diabetes, and the group said that government is the first and most important because he is responsible of coordination of activities to prepare the ground with appropriate policy guidelines so that type 1 diabetes is properly managed. But the government can be under pressure of different demand so that NGOs, academicians, community of patient peer support should be are also different stakeholders that should maintain government awareness. The question of how to convince Ministry of Finance to allocate money to type 1 diabetes was also discussed with, unfortunately, incomplete answer because the discussion is difficult. But the group thinks that the different stakeholders identified should be present at the moment of planifications of the budget of the government, and this is a yearly program, and NGOs should know that, academicians should know that, and community of patient peer support also. About sustainability, the actual model is not sustainable because the patient care depends on, completely depend on external fundings. And this, if the policy change, like we see now with the United States and HIV, then the care will stop. So the idea is to invest in research, in innovative financial model, maybe local production of self-monitoring glucose material and insulin that is near the countries to reduce the cost, and also maybe invest in education to help people to be more autonomous and to take care of their own health. Okay. This is what we discussed in our part.
Yes, and I should say that we kept on extending the group work because the discussions were very lively, which we were very pleased about. And In fact, we're also planning, of course, to continue. Tomorrow there's a workshop session. We will tell you more about the frame tomorrow morning. I'll pass on to group number 3, to you, Kaushik, please.
So the group 3 was co-hosted by me and Professor Baindeka. And first of all, we were supposed to be breaking into 3 different groups, one looking at the health system, the other one looking at the integration, and third one, expectation of people living with diabetes. What do they expect from the health system? But as a group, the consensus was that since the time was short, it was better that we have a discussion together rather than 3 different subgroups. And we had a young Dr. Lucas to basically make the notes, so he'll come and present the group work, and then subsequently we'll come to answer the questions. Welcome, Dr. Lucas.
So, hello everyone, my name is Lucas, I am a medical doctor from Brazil, and I am going to present the summary subjects of discussion and the main message of section number 3, which address the health systems and how do we end the silos in type 1 diabetes care. First, before I started, 1 hour is not enough to discuss a health system, but I am going to try to do a summary of what we discuss. Basically, I can say that we create what I would call 3 main pillars to end the silos in type 1 diabetes care. The first one is a consensus, I believe, from everyone, that is education. We need education actions in all levels. We need to educate and create awareness about diabetes signs and symptoms in the community, in schools, among teachers, because if a patient doesn't receive a proper diagnosis of type 1 diabetes, they cannot receive treatment. So we need education for that. We also need education for clinicians, in primary care practitioners, specialists, and also those that are going to care for patients in the ER, as some of the patients with type 1 diabetes are going to need care in ER due to DKA. So these educational actions need to be continuous, because if there are isolated actions, we can lose the benefit in a couple of years or maybe months, and therefore they should be developed by and implemented by ministries of health. Beyond education, we also need a well-structured and hierarchical healthcare system. We need to, for the healthcare system to work, it needs to be very well structured. We have a patient that may have type 1 diabetes, where this patient are going to go. We need to classify the patient in unstable or stable condition. If the patient is stable, we need to provide transportation if needed, and the means to go to the nearest primary care center to receive care. Otherwise, if the patient is unstable, we need to refer the patient through an ambulance to a ER center, and after the main acute treatment, the patient needs to be referred to the primary care practitioner, that after that can decide if the patient are going to receive care in the primary care center or are going to another hierarchical place, such as secondary or tertiary hospital or specialized center for caring for patients with type 1 diabetes. And the last pillar is kind of summary of everything, that is community actions, because when we are talking about low and middle income countries, we have greater discrepancy between city and rural areas and interior and capital areas. We need to that all actions should be centered in the community, because the one that is in the community knows the needs for those that lives in that specific place. So that's something that is very important. And just to, last thing that we discussed is what those that live with type 1 diabetes expect for the caring of them. And there is two main things. That is peer support, peer education, and seeing other people that also have type 1 diabetes, because therefore they are not going to feel lonely in this world, and they are going to know that there is a life after type 1 diabetes diagnosis. And more than that, those people that live with type 1 diabetes also expect to have others that also have type 1 diabetes included in our structure of care. So this is very important, and more than being included, that this is not voluntary, that they get paid for that, because it is a job, it is something very important. It's not something we are doing because it's fun. It's something you are doing for a living, so you need to receive financial compensation for that. I believe that these three things, education, structure and hierarchical healthcare system, and community action, summarize what we discussed in the breakout sections. Number 3, sorry. Thank you.
Yes, so we actually reached the closing of day 1 with a point called Summary of Main Messages and Discussion Points. And a quick tour through the day in a few minutes would include the opening of the day with remarks from Dr. Bente Mikkelsen, which I guess gave us the broader perspective of the challenges and obligations, but also the opportunities that we can have as a global community to address NCD, type 1 diabetes into the Global Diabetes Compact and as part of the global NCD community that we are part of, while focusing on a specific area like type 1 diabetes. We went on with a very, very important presentation by Sanjana from the WHO Global Diabetes Compact to give us that framework that we designed or conceptualized this meeting in. That Global Diabetes Compact is only 3 to 4 years into its existence, but hopefully has given us a better and stronger framework to advance diabetes care, type 1 diabetes care. Not to mention the goals that have been set, the treatment coverage targets, ambitious as they are. 2030 is not far away. Let's see how best we can join forces and converge. I guess one takeaway from today is that it would be possible to initiate a stronger dialogue around convergence, not for the convergence itself, but for the benefit of health systems and people with type 1 diabetes, because we would be able to utilize the resources better, mobilize the necessary political policy movement, and obviously also the coherence around the resourcing. Type 1 diabetes care is not the only area where resources are scarce, so let's not build a new silo, but let's see how we can balance the approach. To that end, research is very much needed, and we had the global research community representatives in the morning from 3 different perspectives, and also linking us the morning session to the early career researcher track that is of course very important to our conference. We went on to the 2 very comprehensive country perspectives panels. We heard from the government of Tanzania, Ministry of Health, and we heard from the government of Ethiopia, the Federal Ministry of Health. We saw some very comprehensive presentations of the implementation frameworks that are the platform for type 1 diabetes care in these two countries, a mix or a combination of approaches, international partnerships that have been there for a long time, new policy developments, and I think it would be fair to say a progressing Ministry of Health national policy of including type 1 diabetes care, obviously recognizing that there will still be a lot of work to be done. In the same panel we had Tinotenda Tsikiti and Nupur Lalwani, representing people with lived experience, but also representing the wider engagement of people with lived experience, both at a community level, national level, but also as global advocates. And of course, recognizing the fact, and or indirectly you can say, exemplifying that no sector or no stakeholder can provide type 1 diabetes care alone. I think it was very clear in the same second panel, where we had the Ministry of Health of Bangladesh and Rwanda Biomedical Center of Rwanda, again giving some very comprehensive overviews of the type 1 diabetes care within the NCD response, and again very clearly giving the examples of the composition of ownership, which is very multi-dimensional, you can say. At the same panel we had a good example of engagement of a person with lived experience. It was Mark Barone from Brazil, who showed the way the platform and the intersectoral forum in Brazil is building maybe a network a little bit like the one we are trying to build globally here, with so many stakeholders involved. And last but not least, we had Christine Nabatansi from the Sonia Nabet Foundation, who gave us, I think, a very strong statement from local engagement in a village in Uganda. We went on to the broader panel around access to insulin, and I think we knew in advance in the organizing committee that maybe that panel would even have need more time, and nonetheless we heard from the Ministry of Health in Kenya a wide range of perspectives around provision of insulin and access to insulin and devices. We had a statement from the regional office of the WHO in Africa, especially around a new assessment, regional, all 47 member states, assessment of barriers or the situational analysis of the access to insulin and other NCD medications. We have had Africa CDC in the panel. I don't know if Adelard, you're still here, but we had, of course, a broader perspective, recalling the relatively new strategy on NCDs that Africa CDC has launched, but also the entire discussion around local production and regional production. And we had Vanessa from IFPMA giving the perspective of the Association of Manufacturers, of course, very, very critical as well in a point in time where the different modalities of ownership of production and provision of medicines is in a very, I would say, important development. The second panel, again, we went to some country examples from Ethiopia and Bangladesh and Pakistan, but also important remarks from accountability perspective from Health Action International. Then we went to the breakouts we just concluded, and we had some very good discussion, at least in my group, and I have the same feeling from the other two groups. It was very productive. We got a chance to meet in a bit smaller setting, and we're going to repeat that tomorrow, and you'll be getting more information about the format tomorrow. I think it was more or less a fair summary of the day, but you are welcome to make some remarks, or you can say reflection. The dinner is served in 15 minutes, so it's been a long day already, but if anybody would like to have some final reflection of day one, you're very welcome to do so. You're also welcome to take 15 minutes of break before we go to dinner. And otherwise, I thank you for a very good first day of the main conference, and I think we should give each other a round of applause.